Dr. Ghosh, good morning.
Good morning, sir.
We can start, huh? Good morning. Today we'll have a case discussion on solitary thyroid nodule. It will be presented by Dr. Mehul Patel, who is a first-year junior resident at MR Bangalore Hospital. And today our teacher will be Dr. Partha Ghosh, who is Associate Professor of Surgery at Jamuna Government Medical College. So Mehul, you can share your screen, present,
Yes.
wait at the end of history. We'll discuss some part in history and then pass on to the next part.
Yes. So shall I start?
Yeah, please.
Mrs. Fatima Bibi, a 37-year-old lady, a resident of Kolkata and a housewife, presented with a chief complaint of swelling in the left side of the neck for the last 9 months. History of present illness. The patient was apparently well 9 months back when her family members noticed a swelling in the left side of her neck. The swelling was insidious in onset, gradually increasing in size. Initially, it was of size of approx 1 into 1 centimeter, which has increased to the present size of approx 3 into 3 centimeter, not associated with any aggravating factors. There is no history of pain over the swelling, no history of fever, loss of weight or appetite, no symptoms suggestive of hypothyroidism, like breathlessness, trembling, irritability, insomnia, bulging of eyes, increased sweating or heat intolerance. No history of, no symptoms suggestive of hypothyroidism, swelling of the face, whole body, legs, cold intolerance, menstrual problems and constipation. No history of irradiation to the neck, no history of change in voice, dysphagia, dyspnea and stridor. No history of any other swelling in the neck, and no history suggestive of distant metastasis. No history of any surgeries, no history of any TB or its exposure, and no history of medication intake for any chronic ailments. Personal history: takes mixed diet, no history of addiction, sleep, bowel, bladder, appetite normal, married with one child, normal vaginal delivery, regular menstrual cycle, 28 days with an average flow of 5 days duration. No similar illness in the family. Summary: a 37-year-old lady present with a swelling for the last 9 months in the left side of the neck, insidious in onset, gradually progressive from 1 into 1 centimeter to about 3 into 3 centimeter, presently with no symptoms suggestive of hyper or hypothyroidism or constitutional or compressive symptoms.
Okay, go back to the first slide of history. Next. Yeah. Dr. you like to ask?
Mehul,
Yes.
I just give you a suggestion. Whenever you are telling, whenever you are expressing thyroid swelling, that there is on the left side of the neck, it is always better to say it is in the front of the lower part of the thyroid swelling is always present in the front of the lower part of the neck. If you consider the neck swelling, you always need to remember that any swelling in an area which is rich in lymphatics should be considered as a lymph node swelling first, initially, except a swelling in the front of the lower part of the neck, which is almost always a thyroid swelling. So it is always, I think, always better if you say that there is a swelling in the front of the lower part of the neck, just left to the midline or left to the midline. That is, I think, a better description that you can put in your history.
Okay.
Yeah.
Directly suggests that you are dealing with a thyroid swelling.
And when you talk of the area in the neck, there is a defined area in the neck known as thyroid region. Okay. What is that thyroid region? There is a defined area in the neck we described as thyroid region.
Yes, sir.
Where is that area? What is the boundary of area thyroid region?
So between
lies over where?
From between the sternocleidomastoid, above the sternal notch, and below the hyoid bones.
Thyroid bone. Thyroid doesn't go to the thyroid bone. The isthmus lies over the second, third, and fourth tracheal rings. Okay. And each lobe extends below up to the sternoclavicular joint, above up to the upper border of thyroid cartilage. Okay. And on either side, the medial border of sternoclavicular joint, and thyroid usually goes deep to the anterior sternoclavicular joint. So if in this area marked out, this will be thyroid region. Okay, as
Yes,
Dr. Ghosh is saying, he said left side of the neck. Left side of the neck will include the left side as a whole. But if you think of a swelling arising on the left lower thyroid gland, it will be in the front and extending little to the left. And you mentioned about the swelling. Here you need to also mention whether he has got any other swelling in the neck. That another point you should mention, because if the patient complains of multiple swellings, it points towards more of a lymph node swelling. Or if it is a thyroid swelling and there is another swelling, it might be a metastatic node from thyroid swelling. So that point you have not mentioned.
It is what Sari is telling. It is not for thyroid swelling. It is for any swelling. Whenever you are taking history for any swelling, you must have to mention that whether there is any other swelling in any other part of the body. That is mandatory, and very commonly we commit this mistake, and this is very, very important. So always keep it in your mind. Now, next question is that how you took the history of irradiation to neck.
I asked the patient whether they have any exposure, like history of any radiation to the neck, sir.
Why radiation to the neck is so important?
So because some of the thyroid differentiated thyroid cancers, like papillary thyroid cancers, they are more prone in patients who have irradiation to the neck, sir.
Any sort of irradiation to the neck, and any type of irradiation in the neck.
So not so any type of irradiation, therapeutic radiation to the neck.
So it must be a low dose radiation, which is very important, because it has been seen if you give high dose of radiation, it actually destroys the cell, thyroid gland, rather than pushing the gland towards the risk of development of malignancy. This is number one. Number two, any duration that you should keep in your mind?
10 years, 10 to 15 years, sir.
No, it is most common in between 20 to 30 years. So whenever you are, as a postgraduate, you must mention that there is no history of low dose radiation to the neck in the childhood. Because if you consider the age of the patient 37 years, it must be within her childhood or adolescence where he must receive the low dose radiation. So this is the description must be very concrete, so that the examiner understands. You actually know what radiation and what is the duration when it causes, when it becomes a risk factor for development of thyroid malignancy.
Okay.
What is your you also wrote that there is no history suggestive of any distant metastasis. What history you have searched for?
So and the weight loss, jaundice, sir, bone pain, sir, and neurological symptoms.
What common sites of metastasis in thyroid carcinoma? I mean, hematogenous state.
Bone, sir, bone, liver, lungs.
Bones, lungs, liver, right? So you may have in other sites. So bones, whether there is any other swelling or anything that is very, very important in the scalp, the scapula, in the humerus. Like,
Mehul, how common it is to get jaundice in patient with liver metastasis?
So not so common, sir. Not so common.
Yes, yes. Metastasis is a very late feature of liver metastasis. Okay.
Okay, sir.
Asked for whether there is any change in voice, dysphagia, dyspnea, and stridor. Why these? Why these?
So,
These three is
so
very
compressive symptoms. If the
complex.
swelling is huge,
Really, a compression can change the voice of a patient.
sir, there is a injury. There is a injury to the compression to the recurrent laryngeal nerve. Involvement of
No,
recurrent
other
laryngeal.
compression actually, if there is a change in voice in the background of a thyroid, swelling, we think something else.
So, involvement of the recurrent laryngeal nerve.
How?
So, local invasion, sir.
So it's yes, it's local invasion. We always think that whether we are dealing with any malignancy or not. So that is very important. Change in voice with compression is very rare. What is your idea regarding
In
this case?
particular, you said the lump is 3 centimeter. A 3 centimeter lump is unlikely to cause compression.
Yes, sir. Yes, sir.
What is your idea about dysphagia in the background of thyroid swelling?
So again, sir, compressive symptoms. If the swelling is huge, it might compress the esophagus and it causes dysphagia.
Remember that compressing the esophagus is almost impossible in case of a thyroid swelling because of the presence of a cartilaginous structure in front of it.
And
Number one. Number two,
and
it's a very
locals along with the local invasion, sir.
along with local invasion. But I want to say this is generally dysphagia. You must mention it with mention it with caution because it is in case of huge thyroid swelling actually only when the patient complaining of some dysphagia, which is not at all dysphagia. It is actually a discomfort that happens with every movement of the thyroid with swallowing. So patient express it as dysphagia. But as a clinician, you have to differentiate it, right? And again, these compressive symptoms in a case of 3 to 3 centimeter is only possible if it is in the posterior aspect of the thyroid. It only rarely happens. So you must, whenever the history is there, you must mention it with caution.
Yes.
So what is your diagnosis from the history?
So it's probably a benign thyroid lesion, sir.
Benign thyroid lesion. So classify the benign thyroid lesions.
So there's no history of any sudden increase in the size of the gland and history of weight loss or any other symptoms suggestive of local invasion or distal metastasis. So it's a benign lesion and the classical location is in the neck, sir. So it's most probably a case of benign thyroid lesion, sir.
Oh, that's fine. You have I want to know the classification of benign thyroid lesions. And then only we can include or exclude exact what condition we are dealing with.
Oh, acha, sir. So it could be as a colloid. It could be colloid swellings or colloid goiter. Then adenoma, sir.
Can you classify a thyroid swelling? I mean, how the thyroid swelling is classified? Doesn't matter whether it is a diffuse, enlarged, or any discrete swelling. If I ask you what is the classification of thyroid swelling or goiter, whatever you say, uh, then how would you classify it?
Uh,
Number one, it's actually number one. If you classify it, number one, it's a simple goiter. What is the meaning of simple goiter?
Simple colloid goiter. So there is a
How does a simple goiter develop?
so because of iodine deficiency, sir.
What happens? No, no.
So there is deficiency of iron, so it's so the cells
iron deficient. It can be a relative thyroid hormone deficiency itself. Patient in puberty, patient in pregnancy, not always iron deficiency.
Whatever. If there is low level of thyroid hormone, there is increase in
TSH.
TSH. So it stimulates the gland and the gland. So actually, simple goiter is by definition is a euthyroid goiter. The patient remains euthyroid at the cost of rise in the TSH and increase in the size of the thyroid gland. So this is number one, the group where the patient remains euthyroid and the gland is enlarged, which is called a simple goiter. Next come the toxic goiters. How you classify toxic goiters? There are three things. Number one, the Graves' disease. Number two, multinodular toxic goiter. And at last, the toxic adenoma. Then comes the thyroiditis group. After that comes the neoplastic group. We classify the neoplastic groups into two.
Differentiated.
Well-differentiated, yes. A well-differentiated carcinoma or anaplastic carcinomas. Now, well-differentiated carcinomas, again, the papillary, whether they are arising from follicular cells, either it is papillary or follicular, or arising from the parafollicular cells, that is the medullary carcinoma of the thyroid. So this is grossly how we classify, and there are other types of swelling. I am not going into that. So this is, if this chart is in front of you, which group you will prefer for your diagnosis in this particular case?
The colloid goiters and
why are you telling colloid goiters? Colloid goiters, it's a pathological diagnosis. It's not in the list of classification.
so toxic adenomas, toxic.
There are no toxic features. So either it's a simple goiter, simple diffuse goiter, or simple multinodular, where it can present with a dominant thyroid nodule. This is number one. Number two, it may be a neoplastic one because there are the signs of thyroiditis are otherwise lacking in this history, right? So most likely either it's a neoplastic goiter or a simple goiter. In case of simple goiter, it's most likely to be maybe a presentation with a dominant nodule. In case of a multinodular goiter, which is yes. Where now, right now, can we go to the examination part?
Yeah. And more so in case of thyroid neoplasia, you don't expect always that the swelling will rapidly increase in size. Even if the swelling is slowly increasing in size, it still can be a malignancy. A different thyroid cancer grows very slowly. So you have to keep a possibility that it might be a neoplastic goiter also. So I think you can pass on to examination.
Even it doesn't grow sometime for the rest of the life. It also happens. So very careful regarding, and number two, one thing I forgot to mention, that wet loss. Wet loss in the background of a thyroid swelling, it's not a sign of metastasis in that sense. It's not very common. Right, next, physical exam.
On physical examination, patient was alert, conscious, cooperative, oriented to time, place, and person. Karnofsky score is 90, BMI 21, decubitors of choice, well hydrated, no signs of pallor, jaundice, clubbing, cyanosis, engorged neck veins, generalized lymphadenopathy, and left supraclavicular node. No evidence of toxic eye signs and tremors in hand outstretched and tongue. Vitals were essentially stable. Examination of the neck. On inspection, swelling in the left side of the neck, which moves up with deglutition, which is a single overt swelling of size of about 3 into 3 centimeter over the left side of the anterior aspect of the neck. Vertical extent approx 3 centimeter below the thyroid notch to 2 centimeter above the suprasternal notch, and horizontal extent from midline to 1 centimeter medial to the anterior border of the left sternocleidomastoid. All borders are visible and look well defined. Surface appears smooth. Skin over the swelling is normal. Does not move with protrusion of tongue. No other visible swellings in the neck. Trachea is in the midline. On palpation, in sitting position with neck slightly flexed, patient is first examined from the back and then from the front. No localized warmth or tenderness. Single overt swelling of size 3 into 3 centimeter over the left side of the sternocleidomastoid muscle. Vertical extent 3 centimeter below the thyroid notch to 2 centimeter above the suprasternal notch. Horizontal extent from midline to 1 centimeter medial to the anterior border of the left sternocleidomastoid. Surface is smooth, borders are well defined, consistency is firm, freely mobile in all directions. Skin over the swelling is normal, no thrill, bilateral carotid pulse are palpable, examined one at a time, and trachea is in the midline. On lymph node examination, no cervical lymphadenopathy. Oral cavity examination is normal. Percussion, there is no retrosternal dullness. And on auscultation, no bruit over the swelling. Systemic examination is essentially normal. Summary: a 37-year-old lady presents with a swelling for the last 9 months in front of her neck, insidious in onset, gradually progressive from about 1 into 1 centimeter to 3 into 3 centimeter, presently with no symptoms suggestive of hyper or hypothyroidism or constitutional or compressive symptoms. On examination, there is a single form swelling of size 3 into 3 centimeter in the region of the thyroid, which is firm in consistency, moves with deglutition, mobile in all directions with no cervical lymphadenopathy. Provisional diagnosis: a 37-year-old lady with a solitary thyroid nodule likely to be a benign etiology involving the left lobe of the thyroid with patient in euthyroid status.
Yeah.
So from inspection, you noticed there is a discrete thyroid swelling on the left side, isn't it? On the left side, no? Yes. So on the left lobe, it is moving with respiration. Moving with deglutition. So it's most like, and in the region of the thyroid, so it's most likely to be a thyroid swelling. Now, remember, in inspection, you only need to know whether it is a thyroid swelling or not. This is number one, and the lower body is visible or not. If the lower body is visible, then actually there is no need to go for percussion of the manubrium. Am I right, sir? And
some people say that this area is most of the time dull and you gain no information by percussing this area. Some examiner decry that you should not percuss.
whenever the lower body is visible, there is no purpose percussing the manubrium. Not a very good experience either for the patient or the clinician. This is number one. And number two, there is no purpose auscultating this thyroid swelling. Thyroid is actually only available discrete when it is diffusely enlarged in the background of a Graves' disease. Now, so if it is not diffused, it's a discrete thyroid swelling, other in an otherwise impalpable thyroid gland, then there is no need to palpate the thyroid, auscultate the thyroid gland. Right? Now, why you want to examine it from the front? Palpate from the front.
So there's a way of Lahey's method.
Lahey's method.
So,
right.
If you do it from the front, are you standing or sitting in front of the patient?
standing, sir.
Standing. No, it should be the same level with the patient. Preferably, you should be sitting.
Otherwise, it is impossible to palpate, right? So, but the purpose, what is the purpose? The purpose of the Lahey's method, what we need nowadays, that is better palpation of the individual lobes. But originally, when it has been introduced, it was actually, you need to insinuate your fingers behind the thyroid gland, which is not possible to examine from the behind, to look for the posterior aspect of the thyroid gland. That was the purpose of the original Lahey's method. Why you want to flex the neck during palpation from the back? And actually, you should tilt the neck on one side onto the ipsilateral side when you examine one lobe, and then to the other side when you examine that lobe. So, what is the purpose of flexing the neck?
So to make the swelling more prominent, sir.
To make the
Swelling more prominent.
No,
so
no, no.
if you want to make
Flexion
the
doesn't cause
swelling,
prominence of movement.
you need to extend the neck, right?
The
Otherwise,
sternum must get relaxed.
yes, the idea is, sir, what sir is telling. Idea, if you remember, the deep fascia, the layers of deep fascia in the neck, there are three layers: the investing layer, the pretracheal layer, which actually surrounds the thyroid gland, and the pretracheal or the prevertebral layer. Now, if you relax the patient, if you flex the neck, actually the investing layer, which also covers the sternocleidomastoid, is relaxed. So it is better to palpate. If you want to make it prominent, you need to extend the neck. That we also do in short neck person in case of Pigelos method.
Yes. Okay, sir.
What would be your next step? Now you are thinking, it is in your mind that you are probably dealing with a discrete or is it a, now I want to ask you a few questions. What do you mean by a solitary thyroid nodule, and what do you mean by a dominant thyroid nodule?
So a solitary thyroid nodule, it's a discrete swelling, otherwise in a normal gland, and dominant thyroid nodule, it's a prominent swelling in a otherwise clinical palpable gland.
Right. You're almost right. Absolutely. So when a solitary thyroid nodule is a discrete thyroid swelling in an otherwise impalpable or clinically normal thyroid gland, and the opposite is of course a dominant one. Right. Now, what would be your next step?
So doing a thyroid function test, sir. After
What?
clinical
No.
examination, sir.
Mehul, there is a
What?
way of answering
Yes,
thyroid patients. When in breast, you say, I'll do triple assessment. When you go to
got it.
thyroid, you say, sir, I'll go for quadruple assessment of this patient. What is that?
So first we do clinical examination, history and clinical examination, and then we go for thyroid function test. Then we do a radiological examination, USG, and if we suspect, so if we are in a confusion nowadays, we also use molecular and genetic markers.
Quadruple assessment is what you said: clinical examination, thyroid profile, imaging, biopsy, and now one thing is added, that is molecular test. Okay.
Hmm.
So you have done clinical examination. If you talk of thyroid profile study, what are you going to do?
So we'll first of all check for a TSH. If the TSH is low, then we'll go for FT3 or FT4.
No, not
So your voice is breaking, sir. Can you please pardon, sir?
features of, if you have features of hypo or hyperthyroidism in clinical evaluation, you should do
Yes, sir.
T3, T4, TSH. Otherwise, a TSH is good enough. What is normal
Okay,
TSH?
so
What is normal TSH?
for 0.55, sir.
Right.
What?
Milli international units. So milli international units.
Now, if your now suppose if the TSH is very much suppressed, it is less than 0.1, and T4 is less than T4, then what will be your next step?
Please.
What will be your next step? If
So
the
I'll go for
TSH,
USG. If the TSH,
if the TSH is very less, that is, it is less than 0.1, right? And if
yes.
you go for a PT3T4, which is also raised, I mean, simply which indicates a presence of hyperthyroidism in the background of a discrete thyroid swelling on the left lobe, what will be your next step?
So radioactive iodine uptake scan, sir.
Very good. Radioactive iodine scan. What you will look for in radioactive uptake scan?
So we look for if we find a hot nodule or a cold nodule or a warm nodule.
Right. Now, if it is a hot nodule,
So then if it's a hot nodule, so then we'll go for medical management, sir. We'll try anti-thyroid drugs.
what will be your diagnosis if it is a hot nodule?
Sir.
What is your diagnosis? What will be your diagnosis if it is a hot nodule?
So we see sir.
Toxic adenoma. So, what is the management for toxic adenoma? Would you depend on the antithyroid drugs? In a 37, definitely you need to provide antithyroid drugs initially. In a 37 year lady,
So we'll go for hemithyroidectomy, sir.
so you need to go for surgical management in only in rare occasions. You may try for the radioactive. So fine, it's of course. So you have to take some definite action in a young lady, isn't it? Now, if the TSH, if the patient is euthyroid on thyroid function test, what would be your next step?
So going for USG, and if the going for a radiological investigation, USG, sir.
Whenever you have a swelling, you have described the swelling 3 centimeter. This swelling needs a histological evaluation also. So you said I'll do USG. Yes. What in USG is important? How USG going to help you in a patient who has got a solitary thyroid nodule? What are the things you look for in USG?
So we look for the ecogenicity. If the swelling is taller than wider, if there are ecogenic specks in it, vascularity, size and shape, sir.
You will only
And
look at the thyroid gland or something else in the neck as
yes,
well.
sir.
You
So
only
we'll look
want
for the whole neck, sir. Whole neck, sir.
why whole neck?
So because sometimes impalpable lymph nodules, clinically not palpable nodules can
You
be seen,
also
sir.
want to know the status of the cervical lymph nodes along with the thyroid, right?
Yes.
So the purpose of ultrasound is to look for the entire thyroid, number one. Number two, to to try to pick up the risk of malignancy in a discrete thyroid nodule. This is second. And third is to look for any suspicious lymph nodes in the cervical region, in the expected region in case of a thyroid swelling. So these are the three purposes initially. And number four purpose of a neck ultrasound in case of a thyroid swelling is to guide the tip of the FNSE needle if it is justified.
And if you are talking of, you say the ecogenicity, based on that, a thyroid nodule may be cystic, be solid, or it may be complex cyst. What is a complex cyst?
Sir, both the solid and cystic.
Yes. Next is, you can clearly make out the outline of the thyroid gland. If you find that this swelling is extending beyond its outline, what does it implicate?
Local invasions.
So there is extrathyroidal extension.
Extrathyroidal extension.
Next is, if this thyroid malignancy can permeate along the internal jugular vein. Thyroid malignancy is known to permeate along the internal jugular vein. So you can insunate the internal jugular vein, see its lumen. In a normal patient, you see that if you apply the color coding inside, the blue color coding in the internal jugular vein, blood is in the internal jugular vein. You can pick up tumor permeation along the internal jugular vein. And you say vascularity. It will be hypervascular. You say myelin swelling. And then you said you will have the lymph node. How does a metastatic lymph node look like on ultrasonography? If you start with the size.
So there's around or
The size. What size in the neck is important?
Greater than 1 centimeter.
In the neck, 7 millimeter, more than 7 millimeter is significant node. Okay, once in the groin is accepted, but in the neck, more than 7 millimeter size node is significant. Next.
So it's a round, firm.
Farm कैसे होगा तुम्हारा?
Shape. Reniform. Lost.
It is reniform. Normally in a normal patient, if you do ultrasound, it will be reniform shape. It will change size, shape to round or oval. Next what?
So then we look for if it's mobile.
No. You are doing ultrasonography. Look for the ultrasound features. What is then in the center of the node? In a normal node, what is in the center?
So
normal structure is what in the center? Medulla. And periphery is the cortex. So if you insert a normal node, what do you find in the center? It is described as a fatty hilum. It appears hypoechoic. In a metastatic node, this fatty hilum may be lost. If you insert the node, you can see the outline of the normal smooth node. And there is a cleavage between the normal node and the normal tissue. Is it halo around the node? This halo may be lost. And again, vascularity will be increased. So there are these you keep in mind. A lot of the exam will ask you. If you are facing a patient with a metastatic node in ultrasonography, they'll ask you what are the features of a metastatic node. So the other features. Shape, size,
loss of value.
Then irregular outline, extension outside the outline, loss of fatty hilum, vascularity. Yeah.
Now, how the ultrasonography finding is expressed by a radiologist? Is there any system to express it?
Thyroid's classification.
Thyroids.
Very good. Now, in thyroids, if it suggests that you were dealing with something a benign one, what will be your next step? Thyroids 1 and 2.
Follow up, sir.
Follow up.
So we'll follow up the patients.
Would you like to put a needle there?
So if the swelling is more than 3 to 4 centimeters, then yes.
Then they will not tell you that it's a thyroid 1 or 2, isn't it? So if it is a thyroid 1, 2, I mean a benign swelling, if they tell, the ultrasound is so sensitive, there is no purpose putting a needle inside it, right? Now, if it is not benign, then they will tell you whether there is very low suspicion, or high level of suspicion, whatever. So in these cases, whether in all the cases you want to put the needle?
So in suspicious cases, and if
highly suspicious
cases, we'll go for FNACs.
It is high suspicious.
Yes. Increases the suspicion. Actually, the smaller swellings are then asked for FNAC. That means in high level of suspicion, more than 1 centimeter lesions are sent for FNAC. But in very low suspicion, you can wait up to 2 centimeters. So there is a liberty that you can do that, right? Now in cytology, how the cytology, I mean the FNAC system is expressed. What is the FNAC system or the reporting?
So Bethesda classification.
The Bethesda classification, right? Now in Bethesda classification, it is Bethesda 1, you get a non-diagnostic one. What will you do? in this
So
particular
we'll repeat the examination, sir. Repeat FNAs.
repeat the examination. Now, if Bethesda says that it's a benign one, then what will be your next step?
Sir, we'll follow up, sir.
All are
We'll follow.
provided. Patient may have cosmetic issues. Okay. In a benign swelling, if it is a benign Bethesda 2, there is no indication of surgery unless patient is concerned with cosmetics.
If it is 5 and 6, I mean suspicious for malignancy or malignant,
Sir. Sir, surgery, sir. Total thyroidectomy.
total thyroidectomy only will
Again,
come to that.
again, the background of a solitary thyroid nodule, one has to take a decision. There is suspicion of malignancy. Okay. Based on this, you have to take a decision.
Now,
Now
what is
the
the role of your
recommendation is
molecular testing here? What is the role
Sir,
of molecular testing?
in Bethesda 3, sir, when there is a RTP of unknown significance or follicular neoplasia of unknown significance, we go for molecular and genetic testing, sir, for to decide whether
Not only in Bethesda 3, but also for Bethesda 4. That means in Bethesda 3, there is ATP of undetermined significance, as well as there is follicular lesions of undetermined significance. This is Bethesda 3. And in 4, there is follicular neoplasm or suspicious
which are
of
suspicious of malignancy. Yeah.
So
4ABC, both.
Yes. So you have to go for, you can ask for a molecular test. If it is not available, in most of the cases, we don't have molecular testing. Then what will be your next step?
genetics, molecular.
Molecular geneticity is not available. What
It
should
is
be the
very
next step?
common. We actually don't have that.
So then, so we'll plan for surgery, sir.
Yes. So if it is not available, you have to plan it for surgery, right?
3 centimeter swelling, one lobe. What should be your optimal plan for surgery?
Hemithyroid.
Now it is suggesting that you are dealing with a papillary carcinoma of thyroid. FNAC shows that yes, it is suggestive of papillary carcinoma of thyroid. What will you do? Why you want to go for a lobectomy?
Understand? The now scenario is FNAC has shown it's a papillary carcinoma. What should be the optimal management in this patient? It's a PG examination. It's open on either side. You tail and defend.
So it's a well differentiated, sir, cancer. So I'll go for, sir, lobectomy, and as there's no invasion of the capsule.
Invasion of the capsule, how we will determine? There is one way, remember, there are many features which are suggestive of thyroid carcinoma, thyroid malignancy in ultrasonography findings, but until and unless there is breach in the capsule, or there is spray in the adjacent structure, or there are suspicious lymph nodes, you cannot tell that yes, you are dealing with a malignancy. Now, if you put a needle, then it comes to a papillary carcinoma of the thyroid, and in ultrasound there is no breach. You cannot see that whether there is capsular invasion or not. In FNAC, you cannot know. You really don't know that. So how can you decide that you can go for a total thyroidectomy or hemithyroidectomy based on that? Why this controversy? Lobectomy or total thyroidectomy? Why did this controversy remains?
So depending on the size, sir, we can, if it's a signs and other symptoms. Sir. Since this,
can you judge? Are there any
Once you
symptoms?
have a demonstration of papillary plan in the FNA, that indicates a papillary carcinoma. Number 1. Number 2 is in papillary carcinoma, there are people who are in favor of total thyroidectomy because they have their own points. Number 1 is if the size is more than 1 centimeter, Number two, papillary carcinoma may be multicentric. And if you consider the age of the patient is also another risk factor. Okay, so I think at PG level, you can straight away answer with a 3 centimeter lump. You can say, I'll go for the total thyroid. And try to justify your answer. I'll consider doing total thyroid in this patient. Why? Suppose you said total thyroidectomy. How are you going to defend your answer?
So because of the size.
Yes, the swelling is 3 centimeter size.
3 centimeters.
And what is the advantage of doing a total thyroidectomy? Papillary cancer may be multicentric. So I take care of this opposite lobe. And what about in the follow-up? If you are doing total thyroidectomy, you keep the patient on suppressive dose of thyroxine.
Yes.
And how do you follow up this patient? What do you test? Thyroid. If you have a normal thyroid retained, thyroglobulin will not be a good marker for follow-up. What is the problem at total thyroidectomy? The important issue. What? In view of injuries. In view of injuries, parathyroid insufficiency. Okay, that is the reason. Main reason is this.
So what Sat told, if we summarize those points, so papillary thyroid carcinoma is the multifocality is very common. That means almost all, in most of the cases, or in many cases actually, you get a focus on the opposite lobe. But so the people who are in favor of total thyroidectomy, they always say, as it is a multifocal disease, we want to remove the total thyroid, the entire thyroid. But there are the opposite group who are in favor of lobectomy. They used to say that though there is a focus or the microscopic microcarcinoma in the opposite side, if we follow the course of the papillary carcinoma, most of them will never become relevant in the clinically relevant in the rest of the life. So there is no need disturbing the opposite lobe. Again, the most important thing actually, if you go for a total thyroidectomy, the chance of injuring the recurrent laryngeal nerve or loss of parathyroid is of course a bit more. But again, the people who favor total thyroidectomy, they say that those things are safe in hands of a good thyroid surgeon. But of course, what is important that in the post-operative period, the follow-up is very important because number one, you have to suppress the TSH to prevent recurrence. So it doesn't matter whether you keep half of the gland or or you remove the entire gland. You have to put the patient on thyroxine therapy. This is number one. Number two, the follow-up tools like thyroglobulin and radioactive naftalkam, they become paralyzed or they are less effective if you keep one lobe of the thyroid. So these are the arguments that happen, and on basis of what now we are following something. If it is a low risk tumor, now you can put them in MS as these are the systems that you know, so that if it is a low risk system, that 3 centimeters, that means it's less than 4 centimeters, there is no extra thyroidal spread, no lymph nodal spread. In those cases, you may jolly well go for a lobectomy. You can try a lobectomy, but you can, if you say that I will go for a total thyroidectomy, nobody will actually inhibit you telling that, but you have to justify yourself with these points as said, as beautifully told.
Now the scenario may be you had a diagnosis of benign thyroid nodule. Come back, a small guy of papillary carcinoma in the swelling, and the swelling was 1 centimeter. It's a post-op scenario. How do you now proceed?
Sir, can you repeat? Actually, I didn't get
Oh,
the
I said it was a diagnosis of benign thyroid swelling, maybe a adenomatoid goiter. And after surgery, it was a 1 centimeter nodule. And pathologist saying there are foci of papillary microcarcinoma. Now
Right.
the report came
Understand.
Now comes the next treatment.
So radio therapy.
Where?
Again, if you are giving
Why?
radiotherapy inadvertently, you are
Try
increasing
to
the risk
understand. I'm giving a scenario of 1
papillary
centimeter size,
carcinoma.
papillary microcarcinoma. Okay, again, there are two schools of thought. The more important and more rational thought is, if it is a papillary microcarcinoma, these are usually not invasive. And this patient may not have a foci on the opposite lobe. In that case, most of the people will agree that follow-up under close observation is the standard one. Because I'm giving a scenario, 1 centimeter papillary microcarcinoma. So these are the patient, these are incidental diagnosis of cancer. It is not invasive cancer. In that case, follow-up. You have to keep the patient on thyroxine suppression. You want to suppress the opposite lobe. Okay, there is no recommendation for doing a compression thyroidectomy in these patients. Okay.
How will you deal the lymph nodes if they are, in case of a papillary carcinoma of thyroid, if they are not suspicious, either radiologically or during surgery?
There is the note while doing primary surgery, N0 neck.
So we'll go for dissection.
Go for dissection. N0 note. These are the recommendation. You see, you have to answer which is recommended. The recommendation is not that you do elective dissection in a patient who has got an N0 neck. This is recommended only in medullary thyroid carcinomas, where you can go for a elective central node dissection, not the lateral nodes. But for papillary or follicular, there is no recommendation for doing a elective or prophylactic neck dissection with N0 neck. That is not recommended.
What are the indications of central neck node, the prophylactic central neck node dissection in case of well-differentiated thyroid?
If there is nodal invasion or extrathyroidal extensions.
So if you have a high risk, within high risk cases, you can go for that because you may pick up more lymph nodes in that case. And you can actually stage it. Some people argue that staging will be proper. Actually, so you can do that. So actually, you have to, there is, if you now, during dissection, if you find that there are lymph nodes in the left level 3, then what will you?
Level 3 is involved, documented with the imaging. What should be the extent of node dissection?
So central as well as the lateral nodes.
Which node group you can spare? You may not touch.
So
Yes. Is it common to have metastasis to the level 1 nodes from thyroid? No. So Dr. Ghosh has asked, what will be your extent of node dissection when the left level 3 is involved? First should be central. Central is mandatory. Then
central node and then it's a level 2, 3, 4.
So you have to go for lateral neck node dissection and you have to remove the, yes, 3, 4, 3 that you must have to remove. You have to remove the 2, but but you can avoid going above the hyoid bone, and it is not always mandatory to go for the posterior neck dissection of the posterior triangle. because you can avoid it. But
On the
if there
same
is
road.
load in the second, third, and fourth group, then you have to address the posterior triangle. Otherwise, it is not required. How would you follow up this patient? It is a papillary carcinoma of thyroid. You did total
The
thyroid.
first thing I would ask him, what is the discharge advice you give? You have
Right,
done
sir.
total thyroidectomy. You have done
Right.
total thyroidectomy. What is the discharge advice you give to the patient? Patient is going home on third day. What is your advice?
So
जोर से बोलो यार.
So we discharge them with oral thyroxine.
Oral thyroxine. That's why I'm asking the question. Before you go follow up, you are discharging the patient. You will advise the patient to take L-thyroxine from point of discharge.
Yes, sir.
No. You see, if I ask a general question, how you discharge the patient, you have discharge advice for what? The wound. You applied wound sutures, you have to remove after 5 or 7 days. Patient might be needing some analgesics, may not require antibiotics after 2 days. So patient needs some analgesics. And what is the for patient who underwent total thyroid? But you might have leave behind some amount of tissue. Patient might have a metastatic focus. We have not done a metastatic workup. We are not doing metastatic workup for a thyroid patient pre-op. Why? Is not done pre-op in thyroid malignancy. If you have done a whole body scanning pre-op, why you are not doing? Why you are not doing a whole body scanning in the pre-op phase?
So, because if you do a whole body scan before pre-op, so more the markers observed by the
Yes.
clients.
In that case, the whole radiation taken up by the normal tissue. You cannot see the distant metastatic. Okay. So now you have done a total thyroidectomy. It's your time now to prove two things. One is there is no residual tissue in the neck, the thyroid bed, and there is no distant metastasis. Often while doing thyroidectomy, you miss the organ of Zucker-Kendall. What is that? What is organ of Zucker-Kendall in the neck? It's an extension of the lateral thyroid lobe into the sacroesophageal groove. Often you can miss that. Okay. So your advice will be, your idea will be to do a regular scanning.
Radiation scanning.
When you ask the patient to come back, patient may be coming back after 7 days for wound care. With what report? Yes. Thyroglobulin, you do baseline. Don't need to thyroglobulin in the immediate post-op. Before you operate, as baseline, you do a thyroglobulin study. So patient will ask to get a TSH report being done. At what optimal TSH you can go for renal scan? More than? No, 50. TSH should be at least 50 to have a good renal scanning. How is the scanning done? How do you send the patient? Where is this test done? तो बताना चाहिए. Which department? Nuclear medicine. Okay, how it is done? How is whole body radicular scanning done? क्या करना है? बोलो. 131 given parenterally or orally? Huh? Parenterally? No. Why should you give parenteral? Iodine is given orally only. What is the dose? That is a therapeutic dose.
7 to 12.
It's the dose. If the patient and how is the picture taken? Patient stand in front of a gamma camera. And if you see the picture, you'll find they take a picture in the neck. They take a picture of the both front and the back, front and rear. And
So uptake.
what uptake? What you see exactly?
So
There will be steeple dots. There are steeple dots. These are the radioactivity. You do these tests to find out whether there is residual tissue in the neck and any distant metastasis. Also, there is another way to find out the uptake. Suppose you have some residual tissue in the neck, you can measure the amount of residual uptake in the thyroid bed. How to do that? What is the technique for finding out radioactive iodine uptake in the neck? How it is done? They say, no, 18 MD. That is PET scan. I'm not talking about PET scan. You can measure the uptake by putting a Geiger-Müller counter in the neck. You put a Geiger-Müller counter, you have given the patient is that. Because you have to address, if you have left behind some addition uptake, you have to decide about ablating this residual tissue. And this ablation is either by radioactive iodine or by resurgery. Some surgeon has done this and he is not conversant. He has ablating the radioactive iodine because higher dose of iodine. You may need to do surgery. Okay. So they should know at least the radioactive iodine scanning. You see, people
Yes,
doesn't know which device this test is done. Yes, Dr. Ghosh.
Okay, sir. Your communication, I mean, there is some problem in the connection from your side, sir. I'm not getting.
Okay. Oh, not a yes. So suppose you have done a radioactive iodine scanning, tissue in the neck, no uptake in the other part of the body. What advice now? Patient has came for follow-up at the end of 3 weeks. Whole body scanning is done. No uptake. No metastasis. What is your advice now?
we thyroxine and
Thyroxine. What is the thyroxine dose? How do you decide a thyroxine dose to be given? It's a replacement therapy or replacement. The patient will need no. It's a suppressive dose of L-thyroxine. Means utilization of high normal. So it just is for body weight ratio. So you have to adjust it and do the interval for other people. initial years is intensive follow-up. Okay. And then next 3 years, it should be 6 months interval. And then yearly follow-up. What you do in follow-up? Patient has come for follow-up after 1 year. What are you going to do? Patient came for follow-up after 1 year. What are you going to do on follow-up?
So we'll examine and look for TSH.
We'll examine. That means clinical evaluation. Any complaint, any swelling in the neck, examine the neck. Next.
So look for TSH levels.
Anything else? TSH. Yes. Thyroglobulin. Thyroglobulin has shown a rise from the previous. What should be next? In this follow-up, thyroglobulin has shown a steady increase from last follow-up. What should be done now? Scanning again. If thyroglobulin has shown a steady increase, that indicates there is some metastatic disease.
There is either
Now,
recurrence
patient
or
has thyroxine. Yes, Dr. Ghosh.
When if there is rise in thyroglobulin, of course there is some recurrence or metastasis, either in the bed or at the distant side. So again, you have to take care of that. You have to pick it up and you have to destroy that. The principle
Now that
remains the
question.
same.
There is another favorite question. Now patient has an L-thyroxine. When you will order for this whole body scanning? And how can you do that? Huh? 4 to 6 weeks. 6 weeks is quite long time. You see, now there are 3 options.
Yes.
3 options. Stop L-thyroxine. Patient has to go to the near hypothyroid state, which takes us 4 weeks time. And is very uncomfortable. And you need long time, number 1. So one option is stop L-thyroxine for about 3 to 4 weeks. Repeat TSH test and then go for it. Second is now in the market, you have availability of T3. T3 has half-life of 6 to 7 days. So if you switch over from T4 to T3 and then stop T3 for about 1 week time, patient goes to hypothyroid state and do the whole body scanning. Another option is recombinant TSH is available in the market. You stop L-thyroxine, inject RTSH for 2 to 3 days. The whole body scan follow up. You have the option of taking off the L-thyroxine for 3 to 4 weeks. You have the option of starting T3 oral dose and 7 days, or you can give the patient RTSH. You can finish up the scan in about 3 days time. I think 9-10, Dr. Ghosh.
Okay. Thank you.
Yeah. Any last comment?
Yes, sir.
Any comment?
No, it's okay, sir. Fine.
Somebody has asked ability dose of radioiodine. Ability dose of radioiodine is 50 to 100 millicurie. You can give, if the patient has got a large amount of thyroid tissue, a patient may require more, but at one per sitting, it is usually about 50 to 100 millicurie given in a one sitting. You can repeat the dose afterwards in follow.
I think we can finish it today at this point.
Thank you.
Thank you.
No problem.